Per.
Thank you very much, Sven, and thank you for your invitation. And I'm going to talk about pain and spina bifida. And I don't know so much, and no one else does. And maybe that's the take-home message. There are very little research on pain and spina bifida. We are extrapolating the knowledge from pain in a general population and mainly pain and spinal cord injury. But it is not the same thing, and we have to have a respect for that. First, the definition of pain. You can read this here. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And then it's the important thing that pain is always subjective. Another small thing is that the inability to communicate verbally does not negate the possibility that an individual is experiencing pain and is in the need of appropriate pain relieving treatment. And this is very important. What does this mean if we try to translate it to something that is understandable? First thing is that the definition is completely inclusive for all subjective experience or description of pain. That is, if someone says that they have discomfort or pain, they does. We cannot say that, no, you don't. Pain is what a person experiences. And there are no demands for objective or physiological correlates. That's this actual or potential tissue damage or described in terms of such damage. That is, you can have pain, severe pain, pain in agony without having an injury. The definition demands that the individual has a cognitive experience of pain and has the ability to communicate this to the surroundings verbally and non-verbally or non-verbally, so the surrounding can understand. And this is maybe a problem, mainly in brain injury or for those that have difficulties communicating pain. We can also show this as in a picture like this, where we have nociception. I'm coming to what is nociception. That gives a signal up to the brain, where we have perception, cognition and emotion, and very much emotion, because pain is something that triggers our emotional response, our limbic system. And from that we have to communicate pain. That is informing the surrounding, I am in pain, so that the surroundings, the doctors, the nurse or the relatives can act in one another way. So here is, for example, spinal cord injury. There is a stop for nociception if you have an injury to your spinal cord. Instead, you can have neuropathic pain. If you have a brain injury, severe brain injury, then you have difficulties in this pain processing. This is what we mostly think of when it comes to pain, the acute pain, the pain as a warning. You get a nail in your hand, or you get an injury of some kind, and you get a very immediate signal up, and you activate your sympathetic nervous system. And what that is saying us is that something is dangerous. There is an immediate stress, it's a reaction of threat or danger, and it activates what we call the fight or flight reaction. That is, we have to react in some way. And of course that is easy to understand. If you just have had a lion that took a big bite of your leg, then either get out or fight him. But pain also, when you come further on, away from the acute pain, pain means a lot of other reactions. We have the nociception, and when we have had this cerebral recognition about having pain, then we have pain as we have talked about. But then we also have the level of suffering, because pain is suffering. Long-term pain is one of the most devastating things for quality of life. And if you have a suffering for a longer period, you go in having a chronic pain, then it changes your behavior. So it affects how you act and interact with your surrounding. This is a famous painting of Carlo, which she had her spinal cord injury broken and had a severe neuropathic pain. Famous painter. But pain is also depending on, the suffering is depending on what context you have pain in. For example, athletes, for them pain is something maybe not positive, but at least something that is expected. That is, that pain doesn't give a suffering. This is some citations. I don't remember the last time I played without pain. And maybe those of you who look at football, soccer just now, you see all the players have pain. They can't play that match, but that match, and so on. And worse, not being able to play match than having the pain. And you have the citations like no pain, no gain, which is a typical one. So it's very obvious that the experience of pain depends on its context. The prevalence of pain in the normal population is very common. When Breivik et al. 2005 published this comparison between different European countries, the pain incidence varied from, unfortunately in Norway, I'm a Norwegian, so I don't know why Norway is so very high here, 30% down to Spain 11%, and Sweden something around 18%. These are different studies, so it's maybe they are not completely comparable, but around 20% of the normal population have chronic pain, and therefore also affecting their life. The duration of pain in these populations then, they are very much chronic pain. You see here from only a smaller amount was less than 1 year, and most other pains described had been there for 2 years and longer. So down to some pain physiology and what is pain. I talked about nociception, and nociception is just activation of the pain system. It's not the same as pain. As I told you before, you have to realize that you have pain or have nociception before it is pain. And the nociceptors are small neurons out in the periphery registering this noxious stimuli or harmful stimuli. And we most often try to differentiate between different types of pain, and these are the normal ones that are used. Nociceptive pain, which is the activation of pain stimuli, for example burning your hand or cutting your finger or something, or having overused, trained too much, where you also get an inflammatory pain. And then we have the neuropathic pain, which is a pain emanating from an injury in the nervous system. And we should expect this to be quite common in spina bifida, as in, for example, spinal cord injury and multiple sclerosis. Around 40% has neuropathic pain. In stroke, though, only 10%. Idiopathic pain, idiopathic here only means we don't know why this person has pain. It just sounds better to say idiopathic. But most often we mean chronic pain and sensitization. I'll come back to that a little bit. And then psychogenic pain, which is very rare, and for people with injury in their nervous system, it's not an issue. We don't really talk about that. When it comes to spinal cord injury, where we most oftenly compare to spina bifida, as very many have a spinal cord injury in a way, or a spinal cord disease. This is classification for specifically for spinal cord injury, where we have, you remember, the nociceptive and the neuropathic pain. Those are the groups of pain that these patients are considered to have. And then dividing it in musculoskeletal system, visceral pain, neuropathic pain above level, at level, or below level. When it comes to musculoskeletal pain, it's bone, joint, muscle, mechanical instability, overuse syndrome, just going by wheelchair, taking your whole body load with your arms, where the population in general uses their legs. It's a risk for overuse. Visceral pain is also normal, and we could expect that this also in spina bifida. It's kidney stones, obstipation, sphincter dysfunctions, urinary infections, and so on. All this gives visceral pain. But there is also a visceral pain that is more difficult to know what it is. Neuropathic pain, you can have tunnel syndromes, carpal tunnel syndrome, for example, by the wheelchair overuse. You can have syringomyelia. The injury of the spinal cord in itself can give a pain. In a spinal cord injury, we also have another thing that's difficult. It is if you have a lesion where you have no signals coming up from your nociceptors. You remember this? If you have this, for example, if I have a severe complication in my abdomen, for example, a bladder stone or a severe bladder infection or something else, I normally get in pain. But a patient that doesn't get these signals, he can have a very severe complication or even life-threatening if without knowing. So the signals that they get instead is increased plasticity, or if they have a very high injury, autonomic dysreflexia with blood pressure increases. So the conclusion of this is that we have to interpret changes like changes in spasticity or changes in blood pressure as a potential or serious or even life-threatening condition. So this is very important. Over to nociceptive inflammatory pain, the first group that appears in skin, muscle, tendons, joints, and in organs. This is, as I come back to, mainly overload induced. The other thing is the neuropathic pain. This derives from a lesion or a disease in the central or peripheral nervous system. And we divide this in central neuropathic pain, when you have a disease in the central nervous system, like brain injury, spinal cord injury, or spina bifida. But we also have a peripheral neuropathic pain, like in a plexus injury, peripheral nerve injury, like the carpal tunnel syndrome, polyneuropathia, or herpes zoster. An important thing with this is that the extent of injury doesn't correlate with the pain severity. So you can have a very small injury, small in a way, with very severe pain, and you can have a very big injury to your nervous system with no pain. When we decide if you have a neuropathic pain or nociceptive pain, it's very important if you have a change in your sensibility. So we try to investigate and register very carefully if we have hypophenomena in your sensory system, that is reduced sensibility for one or more modalities, pressure, touch, heat, cold, pain, and then mainly which is very important for neuropathic pain, changes in heat, cold, and pain, because those goes through the spinothalamic tract, which is essential for neuropathic pain. But we also register hyperphenomena, sensibility that appears increased, unpleasant, or painful, which is allodynia, which is painful reaction for normal sensation, like touch, hyperesthesia or hyperalgesia, which is an increased apprehension. When we then have this nociceptive pain or overuse or load-induced pain, we tend to get degenerative joints, tendinitis, impingement syndromes, muscle pain. We can treat this in different ways. We can have the treatment with intention to cure, or more or less a symptomatic treatment. The intention to treat is often surgery. It is not really treatment. It is not that you cure because you change what was there originally, but it can be a decompression of a nerve, a joint reconstruction, or arthrodesis. One of our most important parts is the prevention part here, because that is what all of us can work with. For example, having a better seating in the wheelchair, the wheelchair ergonomy, work ergonomy, transfer technique, maybe aids for transfer technique, resting positions, and what Elizabeth was talking about, activity training, which is very important. Also the use of aids. Do you have the optimal wheelchair? Should you have an electric wheelchair? Should you have aids for transfer, walking aids, home modifications, or something else? And then we have the non-pharmacological treatment like physiotherapy, down to cognitive behavioral therapy, and the team rehabilitation, or pharmacological treatment of different drugs. When it comes to neuropathic pain, the treatment options are fewer. Mainly we use pharmacological treatment, where we use tricyclic drugs like amitriptyline, gabapentin, or pregabalin, which is known as Lyrica in Sweden. And if that doesn't work, we go to weak or stronger opioids, and sometimes even to intrathecal treatment with opioids. The non-pharmacological treatments here is cognitive behavioral therapy, electrical therapy like TENS, or acupuncture. The evidence for these treatments are not very strong in this group. The number of patients going to be treated well with this is maybe a little bit more than 50%, which is of course a problem. Sometimes you think that you have a neuropathic pain, but you have really a referred pain from your inner organ. The typical example, if you have a gallbladder stone, which is referred to a shoulder, and you try to treat the shoulder, but it's really that bladder stone. Then over to chronic pain. Chronic pain is a pain that has been there more than 3 to 6 months, but depending on how you decide this. Very often we don't anymore have a pathology. You have this idiopathic pain. And when you talk about this, we talk about sensitization. Immediately when you have an injury, you have a neurological sensitization and activation of different neurons. You can feel that if you, for example, have a pain that is immediate, you feel that that's very sharp. After that, there comes a dull component, and further on you have a pulsating, dull, spreading feeling that is over a bigger area, which is also involving the central sensitization in spinal cord, where you get an activation of surrounding neurons. But when it comes to chronic pain, it's more of this central sensitization of wind up. I think you have heard about the wind-up phenomena, where you have also an activation of surrounding neurons. You have an interaction with the glia, the support system in the brain, and a release of pro-nociceptive substances and different changes. And you also get an activation of what's called a long-term potentiation, or which is really the mechanism of our memory. This is also probably involved in normal memory, but it also involved in activation of pain memory. And that, in a way, occupies your brain and occupies your attention towards the pain. What can we do with this then? Here are some things. This is in Swedish, and I'm sorry that I didn't have that in English, but I tried to translate it. This patient is lying on the couch and saying, "Doctor, I can't handle this anymore." And the doctor says, "No, me neither." Which is not a good situation when you treat pain. You can treat the pain directly, for example, with medication. We can talk about acceptance, which is very important. And trying to explain this, if you have pain, you always try to find a cure, because that is so fearful. And most often you think this is something very dangerous. It's cancer. It's something I'm going to die from. And by having an explanation that this is not dangerous, you're not going to die, I understand that it is a menace for you, very difficult. But you have to focus, because we can't do anything else. So what you want to do, you have to live in some way. And then by focusing on something else, the pain really decreases. So accepting that, okay, this is my situation, I have to deal with that. And also how you behave, being active instead of being passive, how you cope, the activity, being active in leisure and work, handling other symptoms that comes with chronic pain like fatigue. Like one example, fear, which was really what I was explaining, the catastrophizing thoughts, building confidence, and all of these can, even if you have a chronic pain, increase your health and quality of life. We have to be better, I think, in doing a systematic pain analysis, especially as pain and spina bifida is so underestimated. There are so little knowledge. And in this we want to understand the etiology. We have to discriminate between nociceptive, neuropathic or idiopathic pain. We have to know that mixed pains, both nociceptive and neuropathic pains, are common. For example, post-surgery, we nearly always have both a nociceptive and a neuropathic pain because we cut nerve endings. We have to get this information for how to direct our further treatment, only pharmacology, or do we need multimodal, multi-professional interventions? We have to do repeated examinations, and we have to realize how pain changes over time. And these are some things. The debut, was it sudden? Was it slowly evolving? That is, did something happen? The localization, where is it? Is the pain radiating? How does it feel? Dull, burning, cutting, continuous, intermittent? And what is the intensity? And here we very often use some scales, numeric rating scales, for example, where we want to know how is it as worst, how is it as least, how does it change over the day, over the week, over the year. This is a rating scale where we really have more than one rating scale. Here we have the numeric rating scales, 0 to 10. Which is more like the visual analog scale, but with numbers. We also have the verbal descriptor scale and the facial, how do this? Facial pain scale, so it's a name. So there are some other ways. Now I'm going over to the very little that is known about pain and spina bifida. There was a long introduction, most of the talk, because there are not so much to know. There are really two good articles going through, trying to see how common this is. And this is one article by Clancy et al., published in 2005, and then one article emanating here from Stockholm, from the Spinalis that Elisabeth talked about, which is an article by Verhagen. First is by Clancy et al., who looked at quite a few patients. And here is a graph looking at the frequency of pain in these patients. And 18 or 12% had pain every day. Very many more than 1/4 had pain a few times each week. And in total, 56% of the patients reported pains once a week or more often. And compare that to the normal population, you remember 20% that had pain. When it comes to spinal cord injury, we say that 2/3 have pain, more or less. Here another graph. This is the duration of pain by location in children with spina bifida and how often it comes. Short duration pain in head, very common. Ears, eyes, throat, neck, shoulders, and so down to their feet. So it's quite spread over the different body regions. What's interesting maybe is that the constant pain, the pain that is there all the time, is mainly in the lower body, back, abdomen, hips, legs, knees, feet. And we can maybe assume that this is neuropathic pain, which is more constant in its appearance. Here is locations of severe pain reported by parents and children. And there are two things in this graph. One is the discrepancy between the reports from the children, that is the patients, and their parents. And it's shown that parents overestimate the actual pain, the pain that is just now, but underestimate the worst pain that the patient have had last few days. But here we see also that the severe pain, the frequency is quite high. This is 10% should be here. So quite a few of the patients have severe pain in a number of body locations. They also show that pain was reported in locations associated with physiological sequelae, equipment usage or management of the disability. That is, the pain is related to the spina bifida, and that is compared to non-affected children. This is the study by Verhagen et al., published in 2010, you see here, and this was 110 patients with spina bifida in the Stockholm region. 32% of the patients experienced pain, and 20% of the population had pure nociceptive pain, and 10% experienced neuropathic pain, which is quite or very interesting, I think, because, as I said, the spinal cord injury or the multiple sclerosis patients have 40% have neuropathic pain. So this is a very big difference, and I personally would have had expected a higher number of neuropathic pain. But of the patients with neuropathic pain, it seems that it doesn't matter so much if you are male or female. It doesn't matter so much if the neurological level is thoracic or lumbar. Surprisingly enough, it doesn't seem to matter so much if it's incomplete or complete. A little bit higher number for the incomplete injuries. This is something which is quite surprising, that you have an increase, quite dramatic increase with age in neuropathic pain. And as the total number of patients experiencing pain was 32% and the Clancy study was 56%, it's quite surprising that this number is increasing so much in the higher age. And also presence of hydrocephalus and pain. It seems that no hydrocephalus, if you don't have hydrocephalus, you have a much higher risk for neuropathic pain compared to if you have a shunted hydrocephalus. And I can't even imagine the explanation for that. It's still small numbers, so you have to deal with these with respect for bias of variation. 30 minutes have gone. Thank you very much for listening to me.